Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our program's air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud so you can listen anytime. The show is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system that works for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts. So let's just get started here. Dr. Flynn?
Yeah, this is Michael Flynn. I'm a retired surgical oncologist from the University of Louisville, surgery department. Let me begin with the usual disclaimer. Any comments I make represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired rural surgeon from Campbellsville, Kentucky, and any comments I make are those personally of mine and don't represent Taylor Regional Hospital or the University of Louisville Department of Surgery or the University of Louisville.
Well, we have a special guest today, Jeff Bumpous, the Dean of UofL Medical School and the Executive Vice President for Health Affairs. I will introduce him in a moment. And we plan to talk about issues related to the UofL health system and education and training of medical students, residents, and fellows. But before we do that, let me again challenge our listeners to double-check some of the facts that we will be discussing and not accepting everything we say as gospel. From a medical standpoint, the Journal of the American Medical Association, the New England Journal of Medical Medicine are good sources. Go to Wikipedia. You just go on Google and put in whatever topic, and there's a lot of information. Now, I'm going to give one reference to our listeners. There's an article in the Journal of American Medical Association on the 25th of March of this year, 2025, which is entitled, Who Should Own America's Healthcare? And it deals with the issue of private equity in medicine. And there have been a number of articles about private equity in medicine and how it has decreased the quality of care. This article deals with the fact that a private equity company has literally bankrupted a healthcare system in Boston. All right, so Jeff Bumpous. Jeff went to the medical school at the University of Louisville. He did a residency in otolaryngology at St. Louis University, a fellowship in head and neck oncology and skull-based surgery. He was in many years in the department or in otolaryngology. He was division director and then became chairman when it became a department. And he is currently the dean of the UofL Medical School, executive vice president for health affairs. Jeff, welcome to the program. We appreciate your willingness to come on and talk about these important issues, especially the time in this country when the relationship between the central government and universities is really in a strange situation. So as we've done for previous guests, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Gene will begin with the conversation. So Jeff, the floor is yours.
Okay, well, thank you very much, Dr. Flynn and Dr. Shively. Really appreciate the opportunity to be on this program. Obviously, I'm, as was stated, Executive Vice President for Health Affairs at the University of Louisville School of Medicine and Dean of the School of Medicine. The views I express here will be my views and don't represent UofL Healthcare or UofL per se. Obviously, in my position, I'll try to be honest and discuss impact. I am really think healthcare is something of universal interest. I think it's should really be a nonpartisan topic, a topic that's really of interest for the welfare of the country, rather than an issue that becomes highly politicized. So it's very important for the health of our people, health of our nation. Honestly, if you read a lot, many will tell you it's a issue where we have to do a good job of it. We have to do a better job of it. May in fact represent national security interest of our country to make sure that our citizenry is healthy. So part of the importance of that is having a robust ecosystem for educating medical students and residents. And that's my primary focus and passion now, is to make sure that we have a healthcare workforce going forward. You know, part of my role as EVPHA is there are 4 schools on our health sciences campus. There's the School of Medicine, School of Dentistry, School of Nursing, and the School of Public Health and Information Sciences. So 4 colleges on the HSC campus. And all those have a role in really innovating, being thoughtful, and helping protect our individual patients and our population to be a healthy one. Kentucky suffers from a lot of chronic disease and chronic illness. We don't have the best health outcomes in the nation, and we're striving to do better. And through organizations like academic health centers such as University of Louisville, University of Kentucky, that's one of the main parts of our mission. So we want to try to really make impact on making the state healthier and also providing well-educated providers who can have, who will practice in this state and region and provide better access to health care for our patients.
Gene?
Thank you very much, Dr. Bumpous, for being here. I know you're extremely busy and you have an extremely important position. My first question is how is the medical school doing? And what's going to happen if we have NIH grants cut back, and what may happen if we have particularly Medicaid and Medicare reduction in reimbursement?
Yeah, those are things that we're grappling with right now, Dr. Shively, and they're definitely in the front of mind and front of concern. The NIH first, to think about it, you know, in the medical school itself, we are about 75% of the extramural funding of the University of Louisville, and the majority of that is federally based extramural funding. And the top one on that is the NIH. So as most of your listeners are probably aware by now, but if not, at least the executive order that has currently was first under a stay, but now under an injunction, would have decreased the indirect rate to 15%. The indirect rate is really something that's being referred to as kind of an overhead rate, but it's really beyond overhead. Overhead, we think of paper clips and computers and perhaps just basic operational expenses. But the indirect rate is what helped support the infrastructure for science. So like core laboratories, equipment, very expensive pieces of equipment, imaging equipment such as experimental MRIs and things of that nature that are very expensive in order to conduct biomedical research. And those were not expenses that were allowed under the direct expenditures that were given to investigators. So all the indirect rates across the country were negotiated individually by institution with the agency, and that was under the, the legislative mandates to the NIH and to the National Science Foundation and others. So for our rate to go from 57% to 15% is a pretty big cut. So it would have significant impact on our ability to conduct science. We certainly have other forms of funding. We have industry-sponsored research. We have other private foundation-sponsored research. But this would be a fundamental change to us. The Medicaid issue, just in brief, is one that's very important to academic medical centers. And in Kentucky, we are a Medicaid expansion state. So in our program in Kentucky, it's a quality metric-driven Medicaid expansion program that has two facets. One that's called the University Supplemental Plan, or UDP plan. And then there's an ATRIP plan that helps support our rural hospitals across the country in order to provide access to Medicaid patients. Kentucky has roughly about 23 to 24% of its population on Medicaid at this point in time. It expanded a little beyond that during COVID, but that is post-COVID, since some of the expansions of COVID have gone away in the state. Some people have then fallen off of the Medicaid roll. Substantial part of our funding of the medical school is dependent upon clinical funding, and much of that is based on Medicare and Medicaid funding to graduate medical education, both direct and indirect. So if you think of it this way, about 6% of our budget comes from state funds and tuition. About 80% of our budget comes from clinical funding, which is largely dependent on the federal healthcare system programs of Medicare and Medicaid. And the remainder of that is based on grants and contracts, which the majority of which is sponsored funding for research. So you can see how we have kind of a compounded vulnerability in medical schools because of the Medicaid situation and the NIH situation. We're kind of at the confluence of both of those issues.
Jeff, we had Jason Smith on here, did a program a couple of weeks ago, and this is about Medicaid funding. And I don't have the information in front of me, but if I remember correctly, he indicated that the number of patients who were not covered with some sort of health insurance at University Hospital with Medicaid went from being 20% down to 5%. Now, assuming that the National Congress, the legislature, in their ideologic wisdom in some way starts to cut Medicaid funding in order to extend the tax cuts for the rich, how do you, what effect is that going to have on the ability, the financial situation at University Hospital?
Well, I think at University Hospital and the medical school, we know we're very dependent on the Medicaid program. And I think, if you think about the fact that we were, in a sense, both for the indigent care piece, the increased number of people who, if you decrease the number of people on Medicaid and increase the number of people who are indigent, we are still a safety net hospital. So we'll see those patients. We see all patients, at least have endeavored to do that since the existence of the school and the hospital. So to continue to do that, we'll end up having to write off more care. And that can put you in a really tough financial posture and put the school in a tough financial posture. I think the other part of it that's important, Mike, for academic medical centers, particularly in public medical schools, we are teaching the next generation of physicians and nurses. So we're producing physicians that are going to help take care of not only patients today, but patients tomorrow. But we're also, I kind of use the metaphor of we're like bridges on the highway system. If you take us out, then you got problems. You can't. How far can you get on the road? And part of the issue is that the Medicaid funding that supports our programs, our teaching programs in our hospitals, are what allow there to be things like level 1 trauma centers, maternal fetal medicine programs for complicated births. They allow you to have things like a burn center. And if you don't have those things, then there's not a regional ability to take care of those patients. And community-based hospitals can do some of that work, but they're not geared up to do, other parts of that work. So it creates a downstream problem for hospitals that would have typically referred patients to an academic health center. So Medicaid cuts, if they are severe, they really don't affect just Medicaid patients. They affect the whole population. They affect everybody because they will affect the capabilities of academic hospitals to be able to do the enduring work that they do for society, for the state, Commonwealth, and the region.
Jeff, you're the only adult burn center in the state of Kentucky, aren't we?
Yes.
And Children's Hospital is the only one for children, too. Is that correct?
Yes, sir. That's correct.
So that's extremely important that we have those facilities available. And do you make money on a burn center?
Unfortunately, not very much, Gene. Academic health centers, academic medical centers. I can't say for burn centers per se, but in general, no. And the academic health centers who take care of tertiary, what we call tertiary and quaternary care, the average one in the country are making about a 1.5% margin to 3% margin. So it's a low margin business. And that margin in a non-for-profit center like ours is reinvested back into the facilities and its programs. So we're trying to enhance access, enhance capability, and improve outcomes with the dollars that are received in a nonprofit health system. So it's a tough business any way you go. So any reduction of that support and revenue really threatens our ability to network and to deliver the type of care that we really should be able to do for our society.
Well, Jeff, let me make a comment about another issue related to defunding Medicaid, because one of the consequences of that is all of these folks that have access to care, so they're getting treated earlier in the course of a disease, or their mental health issues, or the children getting food. I mean, all of these situations get worse when that access to health care is not available. So the result is the cost is even higher when they end up having to come in instead of a stage 1 breast cancer with stage 3 breast cancer. And the same issue relates to mental health issues and a whole series of situations that are managed with the populations that are dependent on Medicaid.
One of the things,
thoughts,
Mike,
yeah.
one of the things we've done in Kentucky, with why we're kind of proud of what we've done, at least with our version of Medicaid and Medicaid expansion, is we've had a quality metric-based program. And this gets to your point a little bit, Mike. For example, one of those metrics is there's a withhold of 20% of our Medicaid dollars that come to our system based on quality metrics. And if we don't meet those metrics, we don't get those dollars. And part of that includes adherence to guideline-based therapy for screening for colorectal cancer, which is now down, as you're aware, to the age of 45 as opposed to 50. If we diagnose those cancers early in their low stage, they're imminently treatable and curable, and we can do a much better job. If we wait until we have advanced cancers, our outcomes are not as good and the costs are higher. So, one of the things to think about is, the way that we're doing it is to have a quality-based system and to really tackle it that way. So there are good ways to manage this. The other thing, and if you look at this holistically, one of the things that we haven't been able to do is bend that cost curve for Medicare or Medicaid, and the rate of medical inflation continues to go up. So, we have to be engaged and think about ways that we save, ways that we prevent, ways that we do things in a wiser fashion rather than just allow healthcare costs to continue to escalate. So it's a challenging problem. But I do think you hit the root of a lot of it is, food insecurity, providing people with appropriate nutrition, providing appropriate cancer screenings, making sure people have access to getting their medication for their blood pressure. There are a number of things that you can do that are kind of low-hanging fruit and lower costs that keep people out of the hospital and keep people healthier. Those are a few examples, but I think we have to be very engaged as physicians. You guys are obviously engaged in the work you're doing. I think we have to be engaged as problem solvers and try to offer good solutions. And it's a tough problem. It's a tough nut to crack.
In Taylor County, we've done a great job in cancer care. We have a cancer center, and we're able to provide radiation and chemotherapy and surgery, and we're able to take care of approximately 90% of our cancer patients. And we have a relationship with the universities that works very, very well. And so it's been proven that patients who live in rural areas can't travel very far, particularly 90 miles. And so we can provide that service. It's really very, very helpful. We used to have to transfer patients in a van to Louisville to get radiation. And, you're an hour and a half in a van, you have to wait, and they get sick, and it creates a real problem. So I hope that we can continue to do that. Our hospital is 20% Medicaid, and the total of our hospital is 23% Medicare and Medicaid. So if we have cuts, it's going to affect our ability to keep up with taking care of patients in South Central Kentucky. Well, I want to thank the University of Louisville for all the things they've done for us over the years in providing tertiary care and service. We've never had a patient turned down from UofL, and they've always provided great service, and we've always worked very well together with the Department of Surgery and all the surgery subspecialties.
Gene, I think that's right, though. This is something where we have to work in a collaborative fashion and a network fashion to have the best outcome. The more we can keep people close to home and keep both the personal cost and the economic cost of the patient under better control, that's better. It's better for their families. It's better for them. Sometimes this means the university bringing resources to our rural health care partners. Sometimes it's facilitating their ability to get here, get the right patients here for the right reasons. But you're right, we have to work together. I think if we try to work independently, we don't come up with a very good solution.
Jeff, let me ask you some questions about the situation or the status of training in obstetrics and gynecology at the university, in the university department. In many red states, including Kentucky, the anti-abortion laws are confusing. They create an environment where the appropriate treatment of a woman undergoing the complications of pregnancy can actually result in someone getting in trouble with the law, financially and otherwise. The consequence of this is one, residents have got to go somewhere else in order to get the training in abortion management that is required by the board, the American Board of Obstetrics and Gynecology. The other issues, and again, I'm asking your thoughts about this, is that the residents are probably not as inclined to come back here to practice. Practicing obstetricians and gynecologists because of these laws and because of the confusion about how to manage complications of pregnancy, are either retiring early or leaving the state. The younger ones are not coming into the state. And in other states, and Idaho is a good example, I've literally turned into a maternity desert. Now, I don't know if we're there yet, but what's the status of all of these issues at the U of L obstetrics and gynecology department?
Well, we have maintained a strident commitment to take care of mothers and babies. So we're definitely trying to provide services out there for women and women's health. Obviously we have to obey the law. And we're fortunate, Mike, that I'm not aware of any incidents in which any of our faculty has decision making has in any way resulted in any action towards them or any consideration of criminal behavior or anything like that. So that's a good piece of this. We have we use a lot of simulation now in our education. Because of some recent changes in the legislation, we are under a little less administrative burden to demonstrate that we're in compliance with the law. But what the long-term outcome will be in terms of women wanting to come and work in the state, OBGYN residents wanting to come to the program, that it's probably too early to call here. We haven't seen a drop off in applications or a drop off in students here, but we see that has happened in other areas of the country. We'll have to monitor it. I think a little bit in times of early, you guys will remember this some 20 years ago when there was medical malpractice issues in the state of Mississippi that were so bad that they almost lost all of their OBGYN physicians in Mississippi. So, I think local jurisdictions and local states are going to have to weigh the implications on access and availability of care. It's a hotbed issue. It's very. You can talk about this topic for about 5 minutes, and you can, with any given individual, and you can get into a pretty heated discussion, and it can rise to an emotional level pretty quickly. But it's one of those that we keep an eye on. Our commitment is to take care of women in every way that we can. We want to keep our program strong. We have continued strong commitment to our OBGYN program. The healthcare system has opened, or we're scheduled pretty quickly to open a new birthing center at UofL Hospital, Mary and Elizabeth. Be one of the first hospitals south of the Watterson to actually provide OB and maternal care to women in more than a decade. So, our dedication to our patients is there. We will obey the law and we will navigate this and do the best we can for our patients. But it is a complex environment and it's a complex needle to thread for sure.
Jeff, are you aware of any patients at U of L who have complications of pregnancy, for example, ruptured membranes in the second trimester that have to be transferred out of state because of the laws in the state of Kentucky?
I'm not aware of any, Gene. I'm not, obviously I can't comprehensively respond to that question. I don't know, the full breadth and depth of every OB patient that's coming through the doors in the UofL Healthcare system, but I'm not aware of any personally.
Okay.
Jeff, let's talk about something positive. We had Jason Smith on, and I want to get your thoughts about what we talked about. We talked about how U of L Health, when with the collapse of CHI in Kentucky 1, managed to literally put healthcare back together again. If you think of what a disaster it would have been for Jewish Hospital, St. Mary and Elizabeth, Our Lady of Peace, and the Shelbyville Hospital to literally not have any sort of management or coordination or organization, would have been a disaster. And President Bendapudi at the time put together a series of grants, one of which was from the state for $50 million. Now, I may be wrong about this, and you can correct me. And then there was another $50 million from some Jewish foundation and something related to St. Mary and Elizabeth. I don't remember how much money. And the other thing that went remarkably well, was the ability of the university to incorporate the private practice physicians from these places, hospitals, institutions, into UofL Health. And apparently it was done by literally going to their offices, talking to them, including them in the process, putting them on committees. And I mean, it was just so remarkably well done. And Jason indicated that the $50 million grant that was paid off this year. And again, I'd like to hear your thoughts about this, because I think this is a really positive example. You mentioned this earlier, of a nonprofit system that puts its resources back into the system to support its programs.
I think it illustrates two things. First of all, I agree with everything Jason said and everything that you kind of summarized there, Mike. This was, coming out of having a non-for-profit, albeit, but managed care system that was not located in Kentucky and didn't have as vested interests in Kentucky. So the ability to have, the university partner with the development of UofL Healthcare, to work with local foundations to help shore that up, to work with bipartisan support in the legislature and the government of Kentucky, allowed this reconstruction. And you're right, the group that was formerly a kind of a private practice hospital-based group then got assimilated into UofL Healthcare's University of Louisville Physicians. We have an academic medical group and a community medical group in both, but we're really one medical group. We have shared governance with both parties. We have joint meetings. We work collaboratively across that. It's allowed growth of the system. It's allowed us to reassimilate things. For example, our family medicine residency is largely based at Mary and Elizabeth Hospital now, and that was a hospital that didn't have a great deal of medical staff and support. So placing a family medicine residency program there has been very attractive for trainees to come into the program. It allows that family medicine program to really be the dominant force at the hospital, but it's allowed a lot of community engagement of that neighborhood. It's built trust in that neighborhood, and it's really kind of been an exciting really rejuvenation of healthcare in South Louisville. The other thing is that with work and growth, we've built a hospital in Bullitt County. So we have a UofL Hospital South, and we actually just dedicated the Brown Cancer Center groundbreaking out there yesterday for a new $25 million Brown Cancer Center that will be in Bullitt County. So the ability to have people in rural counties have infusion centers and access to healthcare and healthcare providers that's closer to home, much as what Eugene was talking about a little bit earlier. It's been a good thing for us, and it's been a sustainable thing. I started here back on the faculty in 1994, and we've been through a few iterations of healthcare over that period of time. And I have to say that this locally based joint non-for-profit has been a very successful model for us to grow, increase access, engage the community, involve the community, and try to be the best healthcare solution for the community we can. It's also been an attractive place to hire doctors, and where we had in the past had challenges retaining and attracting new talent in, we don't have as much of a challenge in that as we did in the past. So I think for a number of reasons, this has been a really good system, a really good opportunity, and we're still recognizing that. We also, our other major affiliation agreement is with Norton Healthcare, another non-for-profit that's locally based, and that's around pediatrics. Our pediatric operations and pediatric hospital are with them. And that operation has grown. It's allowed the pediatric healthcare access to increase. It's allowed the children's hospital to grow and to grow more programs and to bring in more specialized programs. And the hospital has flourished in a way that it never had before. So, I think this has been a very good model for us as a public university and a public trust to work with the nonprofit community that's locally based to really energize healthcare for our community.
Yeah, it's a really good example of how healthcare can function in a not-for-profit environment. We had Wayne Tuxon on, as you know, Wayne's got his television program, and he was very complimentary about the process of getting of a non-academic physician being included in UofL Louisville Health. Well, let me just make one more comment about the dark side of one example of the dark side of what went on when CHI came into play. I am still on the IRB. I was on the IRB at the time, and I was sitting next to a very nice lady who runs the pharmacy at UofL Hospital, and she was telling me how, and literally she was about to cry. A representative from CHI, this was when they got in the very beginning, they got started, had come in, had sat down with her in the office and told her that she had too many employees. It sounds like something's going on with our federal government. and she was advised she had to get rid of X number of people. And they were doing this based upon at least their understanding of, the functioning of a county hospital. The pharmacy at UofL Hospital deals with all of the academic research that involves drugs. The studies that go through the IRB. I mean, it was just crazy, and it had to do with somebody coming from 1,000 miles away with the wrong set of rules and a misunderstanding of how the situation was working. But it is UofL and everybody who's running it, including yourself. You've done a really great job. Gene, go ahead. I'm not going to rattle on anymore.
Jeff, I want you to talk a little bit about UofL being an R1 university. That means they're in the top flight of research in the country. And I think the medical school is responsible for a lot of that. And I think most people don't realize how much research University of Louisville does.
Yeah, that's a really wonderful point, Gene. There, we're one of about 80 R1 universities, and we're actually what is called a community engaged R1 university. So we do a lot of community engaged research that spans from Calvert City, Kentucky, Owensboro, to Louisville itself, and from any neighborhood you could imagine in Louisville. So we're really proud of that fact. To be in R1, there's really two metrics that they check, and that's the number of terminal degrees that you confer every year, so doctoral degrees, and the amount of research funding you have. So it's a pretty strict objective metric to be in the Carnegie R1 classification. So it is a point of pride for us. The medical school, big part of that, but I'm also really proud of the fact that our medical school really is engaged with the whole university, both the Belknap campus and the HSC. So we have profound relationships and partnerships with the School of Engineering, the Kent School of Social Work, the College of Arts and Sciences, everything from music to public health. We've got people that are doing work across all of those disciplines, and they're doing it with the medical school. I think we've done that. For example, one of the fastest growing majors On the undergraduate campus at U of L is neurosciences, and we've got a robust service line in neurosciences. It's one of our strategic service lines, and that's been a number of people through that bachelor's degree come to medical school. Many of them have been in our MD PhD program. Many of them have gone on to get faculty appointments here or elsewhere or become considerable researchers. So, and they serve as great mentors for like our summer research scholars program, where we'll have over 70 high school and other students here on the health science campuses with interest in health careers and research in health sciences. So it allows us to do a lot of outreach to both the high schools here, Jefferson County Public Schools, as well as rural high schools that are adjacent to here. So it's a big part of our landscape, a big part of our identity, a big way that we can make a difference. At the core of the academy, we want to create and disseminate knowledge. So, and medicine's been one of those places where, we've had a heritage of wanting to keep getting better. We're one of the few businesses, we try to work ourselves out of a job. We try to keep getting better, diagnosing earlier, making people healthier and have less disease. So it's a real pride point, and we do a lot of hard work in that area.
Just 2 weeks ago, I was part of a program where we brought 30 students from Campbellsville to U of L and spent the whole day. We were in the simulation unit and the nursing school, and the students really enjoyed it and had an opportunity to see the medical school and the nursing school and really enjoyed it. And I want to thank you for providing that service.
Yeah, that's great, Gene. One of the things that's so exciting about it too, and this is again where education and really making the plea that education and healthcare are not a partisan issue. As we're fortunate to get a $280 million appropriation to the HSC, and we're going to be building one of the first new buildings we've built in 15 years, which will be one of the largest healthcare simulation centers in the country. And it'll also have laboratories and other services in it, classrooms and research components, but really exciting. And I think that's such a game changer. If you bringing a busload of kids to Louisville, allowing them to experience healthcare, allowing them to be involved in some hands-on learning, boy, that's a game changer, because there are a lot of bright kids in that group and people who will make a big difference if given an opportunity.
Jeff, I'm going to change the subject a little bit, get your thoughts about something that's happened recently, a head scratcher. Apparently, it's medical journals, the Journal of the American Medical Association and New England Journal of Medicine and some others, have got threatening letters from an interim U.S. attorney at the District of Columbia, a guy named Ed Martin, who is concerned about, I love this, partisanship in medical research. Now, this guy has an interesting background that goes way, way off into the far right, and it's something I mentioned earlier, that he's probably got no more knowledge about medical research than I have about driving a submarine. So, what do you think about this? This is really a remarkable situation where a government official who doesn't have any background in this is basically telling medical journals that they're watching the way they're publishing material and doing research. I mean, this is scary business. I don't know if you're comfortable with this, but I mentioned it earlier. I'm just kind of curious what your thoughts are about the situation, and two, what do we do about this?
Well, it's an interesting one. I think, Mike, that it's going. I wonder about the environment that allowed this to come into, into just to put it in context. So, I think a little bit about the fact that so much information that's out there, whether it's in peer-reviewed journals or the public press, people hold it with a sense of skepticism now, and the notions of academic integrity have been things that come into the news. The notions of publishing things that are true and accurate have come into the news. But on the other hand, the ability to conduct research and to disseminate research, we're really dependent on peer review and good journals. And I think the vast majority of journals are quite ethical and they're quite thoughtful about what they produce. They work hard at doing a good job with that. So I think we're going to see something play out in the courts here in terms of the freedom of speech and First Amendment rights and academic freedom, and we're going to see things around the integrity of science and how how science is published, and are we doing that with veracity and thoughtfulness? So I would have to just say it's a kind of a weird atmosphere, and I'm in the I have definitely people who are published. I've published in the peer-reviewed literature. I know you all have, and have sat on review committees for stuff, and I really respect the integrity of that. And I think the vast majority of the medical community tries to do a job with high degrees of professionalism and integrity. So there are just so many concepts that are in conflict here. I don't have a great solution for that right now. I wish I had more wisdom, Mike, but it's one that I think we're going to see a number of things play out. We're at the beginning of what's going to be a cascade of events, I think, if I were to predict this.
Well, I hope that the journals and the universities stand up to the federal government for these kind of activities, because the people that are in this guy, Martin, he doesn't know anything about medical research or peer review. I bet he doesn't even know how to spell that. So, hopefully they'll instead of caving in and, making deals, the law firms that are now going to do $4 billion worth of work for the Trump administration because he didn't like what they did when they had something to do with one of his impeachments. It is crazy time. Gene, go ahead.
Let me change the subject just a little bit. What percent of students at UofL are from Kentucky, and how many of those students end up practicing in Kentucky?
It's a great question, and one that's a little complex to answer, Gene, but I'll take my best swing at it. So we about 65% of our students are from Kentucky. We get roughly about 5,500 to 6,000 applicants per year. About 600 of those, so about 10% are Kentucky applicants. The remainder are out-of-state applicants. But between University of Louisville, University of Kentucky, and the osteopathic school at the University of Pikeville, we do keep the majority of applicants from Kentucky within the state of Kentucky. Obviously, then there's the residency program situation. The people who go to medical school in Kentucky and do their residencies here have a greater likelihood of staying in the state. And then there are other interesting things like a regional campus. We have a regional campus at Madisonville, Kentucky, in collaboration and affiliation with Baptist and Deaconess, another non-for-profit system, Mike. And interestingly, for 22 years, we've had that. We celebrated the 22nd anniversary of that campus last year. In our school here in Louisville, we'll keep about 40% of those students in Kentucky. Sometimes a little higher, sometimes a little lower. On the rural medical campuses, about 60 to 70% of those students will stay in rural counties and rural environments if they train in that environment. It's a very interesting ecosystem, and that's generally around primary care as opposed to specialties. So, if you do your residency and medical school in the state, the likelihood of staying is higher. If you do it elsewhere, the likelihood of moving becomes a little bit greater. So that's kind of the 20,000-foot view of that.
Well, let me ask you one more related question about medical students or trainees in all levels. Do we have a lot of, or any, or few international students in the medical school, the residency or fellowships?
We do have, I can't tell you exact percentage, especially in the residency and fellowships, a lower proportion in the medical school, but we do have international students, and we have international students in the graduate student population, Mike. So, we have an international center. We've been a welcoming space for, appropriately credentialed international students, and we'll continue that commitment.
Well, some of these people have been deported for reasons that don't make a lot of sense in other universities.
Right. I'm unaware of any deportations that we've had so far at the University of Louisville, but and we've not had any ICE events on campus, as you've seen reported around the country. We're committed to those students, committed to obeying the law, and sort of have appropriate guidelines in that regard.
Well, let me go off to another direction. One more thing. We've got about 6 minutes left, so just as a warning, I am still on the IRB as a community member, and we recently had an educational activity about artificial intelligence in medicine. And there were the young man who did the presentation. After I asked him a question, sent me a reference to an article where artificial intelligence was used to evaluate skin lesions, and did a better job diagnosing melanoma than people like you, me, and Kelly McMaster. And then there was another example of AI being used to evaluate MRIs for breast cancer, and again, similar sort of situation. So I don't want to, put you in a position of talking about something you're not comfortable with, but I was wondering where do you think this is going to fit into the educational structure of our medical school, residency, and fellowship programs?
I think it's going to play a prominent role, Mike. I mean, it's here, and it's so we do have to adopt. We have to think about it. We have to think about rational and ethical and professional use of it. There's the educational parts of that, making sure our students know how to use it and use it appropriately, and not use it in nefarious ways. But as far as moving medicine forward, you're right. I mean, it's the advanced machine learning, rapid research computing, and AR are going to be a huge part of our movement forward. I'm really proud of the medical school in the sense that we've got a number of departments in the health system really working forward on this. For example, we've used AI within the diagnosis room to help develop notes for our physicians, which has decreased the time for them to make notes, and they actually don't have to type in front of a screen. They can actually talk to the patient, maintain eye contact, and have actually a very cogent note written about their patient that they can review, edit, and sign off on. So it's actually been when you hear about burnout of physicians and administrative burden of physicians, AI's got a great opportunity to decrease that, and we're already doing that through our electronic medical record. We have pathology, using digital pathology and actually using AI to help improve diagnosis of tumors and areas of tumors because of its great ability to recognize patterns and to look for specific patterns. We're using it in our radiology department now to look at CT scans, particularly around head injury. Not that a radiologist isn't looking at the CT scans, But if a radiologist comes in to read for a particular period of time, the AI algorithm has prioritized the scans that it believes will be most acute or most require more acute care, so they can get to the really important scans quickly. It also identifies adjacent pathology that somebody might not have thought about. I think it's going to be something we need to roll up our sleeves, be very involved with. I think it is going to have a great opportunity to help our diagnosis, help our efficiencies in healthcare. I think it's something we should be engaged in. We don't need to stick our head in the sand like an ostrich.
Jeff, listen, we're about the end of the lollipop here. I want to thank you again for coming on. It's been an excellent program. We've got 2 minutes left, an opportunity to make whatever final comments you'd like to make, and then Paul's going to take us out.
Now, I just, Mike, I appreciate you and Gene's just commitment to healthcare. The notion of taking care of patients you both as physicians know is really a principal and highly professional obligation of ours, and an ancient obligation, really, in many ways. And I think I just my own personal view. I think we have to make healthcare and health of our people a nonpartisan issue, and we have to make it an issue of high priority because keeping our children healthy and safe, keeping our loved ones healthy and safe, keeping our healthcare accessible, keeping the science around it sacred so we have better cures and better diagnoses it is really something that we should all be deeply invested in, and shouldn't be an issue that gets decided at a polling place, in my view. I think this is something that we should all be deeply concerned about and deeply invested in, being solution oriented.
Well, Jeff, thanks again for your participation in the program, and good luck.
I appreciate you guys.
Good luck in your job.
Okay.
Yes.
Thank you very much. We appreciate the thoughts and concerns, because I'm really dedicated to our students and our patients of the region, and hope to do good for our people. Thanks, guys.
Thank you very, very much. I'll keep you in my prayers.
I appreciate that. Always. Likewise.
All right, what a good program. On behalf of Forward Radio and Kentuckians for Single Payer Healthcare, I also want to thank you for taking the time out to come and share your views on these very important topics.
Thank you.
And to our listeners, thank you for tuning in, and keep coming back, and have a wonderful rest of your day.